less travel.
So we wanted to, in building out the day, we started obviously with framing the issue. We know that a number of you are experts in maternal health. We know that a number of you are experts in rural health. Not necessarily do the two always meet. So we wanted to set the stage for everyone to kind of level set. And now, as you've heard about some of the challenges that rural communities are facing, we wanted to highlight some of the things that are happening in these communities, and what better session than to pull together the group that we have here, which is going to be moderated by Tom Morris, who is the Associate Administrator for Rural Health Policies at the Health Resources and Services Administration. I didn't get coffee this morning. Tom is an amazing colleague and friend. As we've been gearing up and leading our work in rural health, I can always call on Tom, and he is always ready to answer and help in any way. And so we are just so incredibly grateful for the partnership, and I will turn it over to him. Tom?
Okay. Well, good morning, Kara. Thank you so much for that introduction. I actually call her more than she calls me, and she's a wonderful resource, and I appreciate the partnership very much. So, again, I am the Associate Administrator for Rural Health Policy at the Health Resources and Services Administration, and while we're located in HRSA, our office has a department-wide responsibility to look out for rural issues within the larger U.S. Department of Health and Human Services. I really appreciate the opportunity that CMS has provided with this forum to bring attention to a really important issue. And I just would really credit Dr. Cosmano and Dr. Hung with the research they did with really bringing this to be a national story. You know, so sometimes rural things happen in isolation and they don't get the national attention they deserve. But in this case, their research, I think, was critical, not just in the academic literature, but in the popular media. They got a tremendous amount of attention, and I think it really started a national discussion that is really important moving forward. And I have to say, within our office, we're pretty lucky. We're a small enough shop that we can fund research and program, and so sometimes our research does inform our programs. And that happened in this case specifically, in the sense that because of their research, we realized maybe there was something we could do with some of our community-based funding. And so in partnership with our Maternal and Child Health Bureau, we're funding a program called the Rural Maternal Obstetrics and Management Strategies Program. By the end of this fiscal year, we will fund 3 pilots in rural communities looking at ways to use a networking approach to improving access to and outcomes related to maternal and obstetric care. And we really hope that these are 3 really thriving examples that will then perhaps inform future program development to address so many of the factors we're talking about today. I'm happy to be the moderator of this panel. I'd like to introduce our panelists. I'm going to ask them to stick to 8 to 10 minutes and get us back on schedule. We'll shoot for that if you can go through your slides rather quickly. But I am happy to be joined by my HRSA colleague. Lee Wilson is a senior advisor in the Maternal and Child Health Bureau at HRSA and also was a key part of that Our Moms program development that we talked about. Our other panelists are Dr. Diana Jollis. She's a certified nurse midwife, an instructor at the Frontier Nursing University, and also provides clinical services at El Rio Community Health Center and at the Tucson Medical Center. Dr. John Cullen is a physician in Valdez, Alaska, president of the American Academy of Family Physicians, and I think a really great example of where you can have great outcomes with low volume in a very isolated rural community. Dr. Jean Howe is a fellow HHS colleague. She's the chief clinical consultant for obstetrics and gynecology at the Indian Health Service. And finally, Dr. Chris Zahn is the vice president of practice activities at the American College of Obstetrics and Obstetricians and Gynecologists. So we'll start with Lee.
Thanks, folks. Good morning. My name is Lee Wilson, and I am the Senior Advisor with the Maternal and Child Health Bureau. And I'm very happy to be here and want to thank CMS for the opportunity, Dr. James, and for my colleagues at CDC and within HRSA and the rest of the department who are here, as well as all of you for taking the time to work on this very important issue. I know that we are sort of short on time, and there are a number of folks who have gone before me who know the data very, very well, and can make the case for why maternal health in rural areas is very needed and important, and that we need to have that as a major focus. So I'm not going to spend a lot of time setting up the teeing that up for you, so I'm going to try to make some of my comments very quick. One, I want to spend a little bit of time talking about the framework for maternal health and an overview of HRSA's maternal health activities and how we support collaboration, as well as highlight some of our key programs to improve maternal health, specifically some of the newer ones, which we are doing. What I'd like to say, though, is that as part of our mission and our goal, we feel that every mother, whether she is white or black, urban or rural, will have the chance, this is our hope, that she will have the chance, the same chance, to see her baby's first birthday. So the mission of the HRSA, the Health Resources and Services Administration, is to improve the health outcomes and address health disparities through access to quality services, a skilled health workforce, and innovative high-volume programs. This is a relatively unique mission in that it puts our federal agency on the ground in the planning and delivery of services to the most at-risk populations in the country. So unlike a lot of the other agencies within the federal government, we are serving as a backbone organization for the delivery of care and the systems to support that care in the United States. I do want to just give a nod to the fact that one of our key priorities is collaboration across the federal government. I'm not going to spend much time on this slide given the shortage of time, but you will see a list of most of the agencies in HHS that we work with in providing coordination of services around maternal health. It's a great collaboration that HRSA has been leading for about 5 years, and we're pleased to have the other agencies as our partners to try to make sure that we are working on this initiative in a coordinated fashion. Next, I want to talk a little bit about the wide array of programs that HRSA has. As I've said, or as I will say right now, most of our programs are not focused specifically on rural, unlike the ones in Tom's office. But most of our programs are looking at high-risk populations and need, and since we know that need is great in the rural areas, a lot of our programs are working with those populations. So we've got the Health Center program, which is the largest program in HRSA, and one of the things that we're pleased to report is that there was an increase in the last year of 17% of the number of obstetricians, gynecologists, and certified nurse midwives, in the last 5 years. And that in 2017, through the Health Center program, we delivered more than 178,000 babies. So it's a huge endeavor within this country, and the Health Center program provides a tremendous amount of support for those that need, especially in rural areas. We also have a workforce program, which references one of the questions that was raised earlier, that trains providers, including physicians and certified nurse midwives. In addition, HRSA's loan repayment program and scholarship programs support providers of maternal services to practice or plan to practice in underserviced areas. So we try through that program to match providers with those areas of need to ensure that there is coverage as best we can. In 2017 through 2018, we trained over 263 certified nurse midwives to support the idea of a cross-support approach or cross-professional approach to providing care. And as Tom had mentioned, our Federal Office of Rural Health Policy has just launched the RMOMS programs, and I'll mention a couple of the measures that we're trying to change through that program. In HRSA, the Maternal and Child Health Bureau provides the largest investment in maternal health in this arena, and its goal is improving the health of America's mothers, children, and families. MCHB is the one federal agency with this responsibility, and at MCHB, we envision an America where all children and families are thriving and where every child and every family is able to reach their full potential. This means that all women should be supported in attaining and sustaining optimum levels of health and well-being throughout their life course. This means that all women would have access to the same level of quality health services, not just some. That's the vision and that's the ideal. But we know that not all women meet this ideal. The data on maternal mortality are discouraging. It's not acceptable that 17 out of 100,000 women who are pregnant will die die within a year of their pregnancy. It's tragic that 60% of these deaths are preventable, and it cannot be acceptable that persistent racial and ethnic disparities exist in rates of morbidity and mortality that are 3 to 4 times greater for Black and Native American women. or that it is increasingly difficult for women in rural areas to access the basic care that they need to support healthy pregnancy. You've seen this map already. We just changed the color to red to make it seem more extreme. These are the counties that are underserviced with obstetricians and obstetrics care facilities. They're in the slides, and there's more information on this. But it's striking to see the sections of the country and the vast amounts of our country that have limited to no access for pregnant women. So what do we do about this? MCHB has been asked this question by the administration, as Kellyanne Conway had said earlier, by Congress, by GAO, by OMB, and many, many others. As we have formulated our thinking on our strategy, we've identified 3 key areas where work is needed. The first is access, increasing access to quality, evidence-based, increasing access to quality evidence-based care for women of childbearing age by improving and strengthening health systems, clinical service delivery, data-driven quality improvement, and workforce development. And a nod to our CDC colleagues, data, building data collection and analysis capacity to improve our understanding of the causes of and effective strategies to address maternal mortality in the United States. And finally, innovation, supporting innovation to ensure that pregnant women have access to and receive appropriate and timely care, and supporting programs that make that access easier and normal. As I mentioned, MCHB has a suite of existing programs that provide the backbone and infrastructure for maternal care and at-risk women. Within MCHB, our largest program is the Block Grant, the Title V Maternal and Child Health Block Grant, which totals about $600 million a year, and leverages, it's estimated approximately $6 billion a year in funding and support for maternal and child health. The Block Grant funds all 59 states and reaches 56 million people, including 86% of pregnant women and 99% of infants. As the Block Grant provides great flexibility to the states to address the unique needs of mothers and children, it also mandates accountability through the development of needs assessments every 5 years and the development of action plans to meet national performance outcomes and measures. To make progress, many states are exploring strategies like increasing well woman visits, preventing low-risk C-sections, and reducing smoking. Our second largest program is the Maternal, Infant, and Early Childhood Home Visiting Program. It is a competitive program. It's actually a formula-based program that goes to the states for $400 million a year, and McPhee funds states, territories, and tribal entities to develop and implement evidence-based voluntary home visits for at-risk pregnant women and parents of young children. I want to underscore that this is an evidence-based program that selects models to be delivered for care in through local implementing agencies. Home visiting services include education and support to promote a number of preventive health practices, including prenatal and postpartum care. Home visitors conduct screenings and provide referrals to address maternal depression, substance use disorder, and intimate partner violence. Funds are awarded to states which are charged with identifying areas of need through their local implementing agencies and delivering models that are most effective in addressing those needs. Over the life of the program, McPhee has provided more than 930,000 home visits, and we feel that this is having a huge success on some of the areas that are of greatest need for young families, and with a special emphasis on rural areas. The third program I want to talk about is our Healthy Start program, which is the Healthy Start initiative, eliminating disparities in perinatal health. Healthy Start works to improve health outcomes before, during, and after pregnancy, and to reduce racial and ethnic disparities in rates of infant death and adverse perinatal outcomes. The program provides grants of about $110 million a year for at-risk communities, with infant mortality rates at or greater than 1.5 times the national average, as well as high rates of other perinatal outcomes like maternal morbidity and mortality. Healthy Start funds support implementation of community-based interventions to support some of the most vulnerable populations of women, children, and families. And although the primary goal of the program is to address infant mortality, we know that many of the interventions that address the well-being of infants are the same interventions that address the well-being of the mother. As such, Congress provided us with an additional $12 million this year in fiscal year 19 for clinical support to be provided at all of our grant sites to address maternal health and prevent maternal morbidity. So we were very pleased to receive those dollars and to see the robustness of the program, both at focusing on infants and on mothers. I'm going to spend just 1 second referencing our AIM program, which I think is pretty well known to many people here. Dr. Zahn's also going to mention it, who's also on the panel. AIM is the Alliance for Innovation on Maternal Health, Combating Maternal Mortality. AIM is a very visible and promising activity. It's a national data-driven maternal safety and quality improvement initiative based on proven implementation. The end goal of AIM is to eliminate preventable maternal mortality and morbidity across the United States. AIM works through state teams and health systems to bring about hospital-level quality improvements that make a difference overall in maternal health outcomes. We're pleased to announce that AIM is working with 27 states at this point and more than 1,300 hospitals to implement safety bundles through those hospitals in the delivery of care. We estimate the program is reaching about half of all births annually in the United States, and through AIM we are also able to address emerging issues. For example, AIM is developing a safety bundle on the prevention and treatment, or has developed a safety bundle on the prevention and treatment of opioid use disorder, as well as neonatal abstinence syndrome. We'll give a quick shout out to our WIPSI program, the Women's Preventive Services Initiative, which is our preventive services program, and I'm going to take 2 more minutes since I'm getting to our new programs, which I think people want. This is on the back table. It is the periodicity schedule that our WIPSI team has worked on for the development of preventive services for all women. WIPSI was developed as a result of the Affordable Care Act in requiring that preventive services be provided to all women through private insurance at no cost sharing. And we're very pleased with that program and see it as foundational to the requiring the type of care that women need. We have a couple other programs that I did want to mention. First is our screening and treatment for maternal depression and related behavioral disorders program. This is a program that's targeted to support psychiatrists and other clinical care workers to give them enough support and services to treat and diagnose mental health disorders, especially with perinatal women dealing with maternal depression and other emotional health issues. We also have our Bright Futures program, which I would just highlight as a blueprint for well child care that, coupled with our preventive screening activities, is really an upstream approach to ensuring good preventive care for young women and women in their birthing years, because we do want to take a public health approach to ensuring health regardless of whether or not a woman is pregnant. We do a Shark Tank sort of program through our through our grand challenges, which is occurring throughout the federal government. It's a competitive process where it's a non-traditional grant program where innovators try to pitch their program. Tech people usually present their ideas, and they go through a series of rounds of competition. One of them is our remote pregnancy monitoring challenge, and one of them is an opioid use disorder challenge. We did have a summit, a global summit, which identified 8 key areas for or recommendations. This global summit brought together experts from the United States and 5 different countries outside the United States to provide us input on what is working and what recommendations they might provide to us to improve maternal health. That report is online, so I won't detail the 7 recommendations that they made, but they are consistent with what I have said already, and we are taking those recommendations and implementing in the programs that we have been supporting. Congress provided to us, in 30 seconds, Congress provided to us $38 million in new funding in 2019 to address maternal mortality. I've already mentioned the $12 million that was provided for the Healthy Start program. We received $3 million additionally for the support of the AIM initiative. So some of that funding is going to go into AIM to expand the reach of the program to all 50 states, jurisdictions, and tribes. We're also going to expand AIM to look at non-clinical, non-hospital-based services so that it's not only focused on the delivery setting. The largest amount of resources that we have for the program that we received in maternal mortality funds this year is going into our innovations program, which is going to be a state-based program looking at models, building off of AIM and some of the other activities that are going on to take a state-based approach to addressing maternal mortality. That will be about approximately $20 million that we will be providing to 9 states, and that competition is out on the street now. If any of you are representing states, you have till July 15th to put in your application. I would encourage you to do that. We will be providing technical assistance, a technical assistance initiative through that program as well. I did mention the RMOMS program, and I need to go. So thank you very much.
Am I next? All right. Hi, it's my privilege to be here. My name is Diana Jallis, and I am coming to you with 3 lenses. I've been a nurse midwife in public health for 20 years. I started with the National Health Service Corps. I married into the federal service, and that has caused me to move every 3 to 5 years, which then gave me my second lens, which is that of being a nurse researcher. And my passion is unwarranted variation in care. My third lens relates to my role as a nurse educator. I work at Frontier Nursing University, and our mission is to grow the advanced practice workforce, specializing in rural health and care to underserved populations. In the past few years, I've been privileged to work in hundreds of rapid cycle improvement projects nationwide. And I want to share 3 lessons that I have for us as we consider our issues with regard to rural health. And they're lessons that I teach our students, and I hope we can keep them in mind. This issue of surge capacity. So Senator Maureen Walsh made this very interesting statement about nurses playing cards in critical care access hospitals, which wasn't well received, and it blew up nationwide. The message and the context about it being critical access hospitals got lost, though. And that was an opportunity lost, because it's an important issue, but I would challenge us to realize that this issue is going on in urban settings every day. Our administrators in Tucson mistakenly said this year that our nurses were drinking tea, sitting around drinking tea, which then led them to make embroidered teacups, because if you're not gonna laugh, you're gonna cry. So we need to be very expansive, and we need to remember which things are actually special issues that are unique to us, which things are contextual issues that have root causes. And surge capacity's root cause is in our reimbursement system and in funding procedures over quality. And so until we fix that, we're not going to get anywhere. 2 elephant stories for you that I think are really important. If you're familiar with Aesop's fable and the 6 blind men and the elephant, bringing multiple stakeholders around this issue and coming together in consensus is how we're going to find our way. So I want to commend ACOG and SMFM and all of the trauma levels of care work that has been done nationwide. It's very important, and it's a very essential infrastructure. It's one side of the elephant, though. The levels of care work is from a technocratic standpoint. So it's looking at which technologies we have and getting the right people to the right places at the right time. But the majority of childbearing women won't need that high level of care. And what we need to do in our levels of care work is make sure that we're well representing basic care as an enhanced care primary care model that's essential in our primary preventive healthcare system. So the second elephant story that I always share was taught to me when I started leadership at Denver Health Medical Center, which at the time, their motto was level 1 care for all. And I learned in a leadership seminar, don't think of elephants. Whenever you're going to start a project and you say to a group of people, don't think of something, what do they think of? Elephants. So it's the opposite thing we should be doing when we tackle really hard issues, and we need to make sure that we're not forgetting the appreciative nature of what we're doing. Rural health is challenged. But rural health, as a provider who's worked in both rural and urban settings, rural health is a leader in our nation. And it's really important that we don't forget that. My first 5 years were spent in a rural health practice with the National Health Service Corps. 1 in 200 of our births were ended in a NICU admission. Now, this is a low-risk group of women, 1 in 200. My next practice was in an urban setting caring for a low-risk population, where 1 in 4 women had babies admitted to a NICU, because the hospital you give birth in drives utilization, and that's how our payment system is structured, and it is our job to fix that. So we have to embrace the strengths of the rural workforce and the quality that's there and go after the best practices. So with regard to workforce, in the 1970s, the IOM talked about team-based care, and we've made remarkable improvements on this issue, but not enough. And our rural workforce exemplifies this. We have best practice, and I'm going to shout out to my colleagues at Tuba City in Arizona serving the Navajo population. I come to DC and I sit in National Quality Forum meetings where we talk about, very educated professionals will talk about why our cesarean rate has to be so high because of the obese population, because of the population of diabetics, which are growing. But I've served in rural America with the Tuba City team. So they have a different model of care, and they're known for having benchmark rates of appropriate NTSV and some of the highest rates of exclusive breastfeeding. So we have to question our assumptions and start learning from the high quality care that's happening. Healthcare equity starts in the community with a diverse workforce. So I want to talk about the results of the Center for Medicare and Medicaid Innovation Strong Start for Mothers and Newborns project. This was a 4-year innovation grant that concluded, and the report came out in November of 2018. There are 46,000 Medicaid beneficiaries included in this project. 70% are from minority groups. A half of the childbearing women were unemployed and not in school. A fifth suffered from food insecurity, and 1 in 4 screened positive for depression. This is a robust mixed method analysis that compared 3 innovations: group prenatal care, the maternity care home, and birth centers. The impact analysis provides us with unprecedented information. There is a matched cohort of Medicaid beneficiaries matched by geography, matched by social and medical risk factors. Those beneficiaries never had any encounter in any of the Strong Start models. And then there's an internal comparison looking at traditional care and the medical home compared to group care and birth center model. So if by now you've kind of thought, blah, 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 birth center, birth center, birth center, I just want to make sure we're all together on our operational definitions of things. This ABC birth center cohort had 45 birth centers in 19 states, and 10 were rural. We have Alaska, Florida, Nebraska, New Mexico, Oregon, Tennessee, Texas, Wisconsin, and West Virginia. The operational definition of a birth center in this model is an integrated primary home, okay? So people come, the birth center model isn't about the place you give birth. It's about the site of care for the perinatal episode, which starts prenatally and continues through the postpartum period. We achieve high quality outcomes because of our essential collaboration with obstetricians, perinatologists, and a reliable system that allows you to triage antenatally, intrapartum, and postpartum to get people the right care at the right time. These practices are characterized by things that are not commonly reimbursed by Medicaid: yoga, group care, community gardens, and a high level of intensity of engagement, empowerment, and listening to women, spending more time. So when you look at births by location, you'll see that the majority of births in this study were actually hospital births, many of them planned not by medical necessity. 35% of the birth center practices offer hospital birth by choice, and women are empowered to make those choices based on their medical risks and personal preferences. The majority of the people cared for here were attended by midwives in birth, and 35% of the births are attended by our obstetric, family practice, and maternal fetal medicine specialists. Our outcomes are important. The birth center demonstrated high-quality outcomes. It was superior to the matched Medicaid cohort. It was superior to the medical home. When compared to typical care, the birth center model expended fewer resources, demonstrated decreased utilization, lower costs, fewer ER visits for moms and babies through the first year of life. After controlling for demographic, medical, and social risk factors across every ethnicity and race, there was statistically significant decrease in preterm birth, low birth weight, cesarean, improvements in breastfeeding, longer gestational age, and more weekend deliveries, which shows a decrease of overutilization. This is high-value care, and the processes aren't well supported by our current Medicaid financing system. The estimated cost savings are appreciable. There's 21% lower cost for birth. There was 16% lower cost in the first year of life. And the average cost savings per Medicaid beneficiary was $2,000. So that's the triple aim: improved quality, higher value, and client satisfaction. 96% of the Strong Start participants reported being very satisfied or extremely satisfied with the quality of their care. This model is scalable with the federally qualified health centers, with our IHS partners, with our rural health facilities. This model is scalable. We can empower existent community-based health systems to use the Commission for Accreditation of Birth Centers accreditation standards and processes to guarantee that this model can be spread effectively. The payment mechanisms have to shift from paying for procedure to paying for quality. We are under the illusion that every system needs to be able, not truly, but as a society, we are in the illusion that we better be ready to provide level 3 or level 4 care at any given moment. And while I'm not going to say that that can't happen, there is over-amplification of population health risk. What is more common is the underutilization of basic level 1 care and the appropriate level of care to the majority of Medicaid beneficiaries. Underutilization of reliable, effective screening tools and the appropriate transfers of care to higher levels of care need to occur. It's currently being underutilized. We need to decrease the overgrowth of surgical ICU units for normal childbirth in America. We need to use the national quality levers of innovation and diffusion, mandatory public reporting, measurement, and feedback, the processes of certification, accreditation, and regulation. Being a Black woman in the United States today, a Black childbearing woman, is the 5th most deadliest job in America. I've been doing this 20 years. If we wait another 20 years to take major change, another 14,000 people will die. Moms will die. 66% of those deaths being preventable.
Kind of backwards. Oh, that's okay. So I'm John Cullen, and I'm the president of the American Academy of Family Physicians. But actually, the reason why I'm here is that I'm a practicing rural family physician, practicing in a town of Valdez, Alaska, delivering babies for the last 25 years. And I don't think I have a pointer on this, but where I live and where I practice is that small, actually a fairly large census area just to the left of the Panhandle, but just on the bottom right corner of the state of Alaska. that area is about the size of Ohio, and my community is 4,000 people. We're 300 miles from the nearest other tertiary care hospital. And yet, we can deliver babies, and we've been doing it successfully for 25 years with a lower infant mortality rate than the national average. I used a slide of the frontier designated areas, which is based on population density and how far away from the nearest tertiary care hospital. This was in 2010. Given the rate of hospital closures in this country, especially in rural communities, actually that this map would be a whole lot more green. This is the reality is that people have to travel inordinate distances, not only for prenatal care, but as well as delivery. And distance matters. It's one of those things that if you are 90 miles away from where you're getting prenatal care or you're going to be delivering, there's a very good chance you're going to have worse outcomes and you're going to maybe even deliver on the side of the road. And at 120 miles, it's even worse. So this is our hospital. We realized early on, at least I did when I first moved to Valdez, is that even if we were not going to be providing obstetrical care, we would still be providing obstetrical care. We just wouldn't be ready for the emergencies. And that really was highlighted by one of the first deliveries I did in Valdez, where we ended up having to do a C-section, and we were not ready for it. Our nurses weren't ready. Our charge nurse had to be our scrub nurse. It was the middle of a major storm. And it was just a very bad experience, although mom and baby did fine. And but the result of that is that we decided that we really needed to get good at this. Even though we were a low-volume hospital, the reality is that we would still be delivering babies. And the problem is that rural and frontier communities still take care of all of the same issues that major metropolitan places do. We take care of trauma, pregnancies, surgical cases, but that distance and transportation can be limited by weather. It turns out that air transportation by, like an air ambulance, is one of the most hazardous occupations. It's actually more hazardous than being a deckhand on the deadliest catch. And you have a limited medical staff. So that's actually the view right outside of the hospital. And where I live is one of the most beautiful places on earth when the sun is shining. But it also looks like that's actually my house. And the interesting thing about that picture is that we actually have a 3-story house. We have a lot of snow. And it also looks like this. I don't know if you can see the skiers at the bottom of the picture. Or this. So this was an avalanche that closed off the road, cut us off from the rest of the state. And that avalanche is 80 feet tall and extends back a quarter mile. And then on top of that, there was a lake that formed on the other side of it, so we couldn't actually take care of it. And the point of all this is that because of the weather conditions and the distance that we have, that we actually have to just take care of whatever it is that is in our community. That's where our town is at that. And the thing about this picture, this looks at infant mortality, and you can get these figures for every state in the union. Our area is around 3.3 per thousand. That's historically, that's just where we've been, which is less than the national average. And in that area, we have 4 family physicians. And this is really an incorrect picture because we also have a whole team of nurses that we work with. We do not have a dedicated obstetrical nursing staff or a dedicated physician staff. We do everything. And I'm really happy about this picture because this is Karina, who joined us just recently. She was a recent graduate from residency, and that allowed me to be able to speak in front of you today. So one of the things that I found, and I traveled with Tom Morris with the Rural Health Advisory Committee, and the one thing we found is that when you look at one rural community, you've seen one rural community. But we all have to deal with the same things. We have to take care of emergency medicine. We have to take care of some sort of inpatient or figure out what we're going to do. We're going to be delivering babies whether we plan on it or not. And we have outpatient clinics. And with our 4-family physician model, we can actually do all of those. And like I said, even if you're not planning on delivering babies, you're still going to deliver babies. And the other part of that is that if you don't offer obstetrical services, you still have people coming in premature labor. You have to decide what you're going to do about cesarean section, because sometimes it just does not work to wait on that. That's something that needs to be done on a timely basis if it needs to be done. Our C-section rate is not as low as at the birthing centers. It's about 17%, but that's half of that of what it is in Anchorage. I would love to get down to 12%. But the reality is that we also don't have a NICU, and so we are a little bit more conservative. The thing is that by having that capability, by being able to perform cesarean sections, and that means having the nursing staff that is operating room capable, it means being able to do anesthesia, we have increased capabilities of handling other issues. But it takes a culture, and that culture is really that everybody is on deck. And when we have something happen, everybody is there. And when we are doing a cesarean section, all the physicians are there. So these are twins that I delivered. I had never any intention of delivering twins at all. This is the second set I delivered. I was really hoping to make it through without having any. These were twins that I delivered to a mom at 31 weeks. And this is one of those cases where we knew she had twins. We were planning on having her go to Anchorage at 31 weeks to continue out the rest of her pregnancy. She had 2 other kids. So leaving Valdez was a major obstacle for her. And she was the primary breadwinner for her family. And so this was a big deal. I saw her on Friday. On Monday, she was going to Anchorage. She came in on Saturday in labor, dilated to 7 centimeters, and the cords for both babies coming through her cervix and we're in a bag of membranes. We ended up keeping her pregnant for about 7 hours until the weather got better, and then actually flew a NICU team into Valdez into the section there, because if I had put her on the plane and the membranes had ruptured, we would have lost one or both of these babies. The thing is that we would not have been able to take care of this unless we had that commitment as a community to take care of obstetrical cases. And with 4 family physicians, we actually do a lot of our own anesthesia. We could do a lot of surgery. But we don't do it like we have a surgeon and an assistant. We actually have both are really very similar roles. And then a pediatrician, but the pediatrician, again, as a family physician, actually watches to make sure that the other 2 are doing everything correctly. It's a much more of a team approach to how we do it. And it works. And like I say, we include the nurses in all of this. But the reality is that only a little more than a third of maternal mortality occurs at the point of delivery or the week following. That means that about another third is in the pregnancy itself, and another third happens in the year after the delivery. And that means that those 2 areas in particular are going to happen within the communities that women live. And even the 36% that occurs at the time of delivery, most women are back in our communities within 24 to 72 hours from when they deliver. And so a lot of those complications are occurring in rural communities, and if a community is not able to handle obstetrical complications, then those women are not going to do well. The scariest case I ever had was a 12-week miscarriage where I had a patient almost bleed to death just going from the ER to the OR, which was about 120 feet. And if we had not been able to do a D&C, then we would have lost her. The thing is that women in rural communities, even when they are transferred to metropolitan areas, don't necessarily do better. And this is a study that's an old study from the 90s when the maternal mortality rate was better than it is now. But what they found was that in high outflow communities, those are communities where most women go and deliver in metropolitan areas, their complication rate was higher than those who stayed within those rural communities. And stress is a big part of that. Like I said, I had a patient who had 2 other children, and she was the primary breadwinner of that community. The stress of living in a big city is substantial, and we don't know what the impact that stress has on pregnancy, except that we know that it has a huge impact in terms of premature labor and in terms of worse outcomes. And it'd be nice if everything was just all smooth water. But But sometimes you have to do cesarean sections. And so we've developed techniques. We do intrathecal anesthesia instead of epidural because that way we can do a spinal. And if we can do spinals, then we can do appendectomies. We can take care of ectopic pregnancies. That's another condition you can't wait for. We can do cesarean sections. We can do LPs for meningitis. But there are some caveats. We do risk stratify to a tremendous degree, and we work very closely with obstetricians and maternal fetal medicine specialists in Anchorage, just to make sure that the patients that we have are appropriate. We are not doing VBACs, vaginal birth after cesarean, and we don't recommend home deliveries. And that's because we really are there the whole time somebody is in labor. We also have Medicaid expansion in Alaska, and that was a huge factor. That really is a big one. And we drill. We drill for those low occurrence cases, and that whole AIM program is really important for that reason. So we had a recessiani that had lots and lots of cesarean sections. Telemedicine is a tool. It is not a solution. Workforce is the solution. Having a facility to practice in is the solution. But to the extent that telemedicine really allows us to do our job in these rural communities, then it's a real godsend. And I use a lot of telemedicine. And the thing is, like I said, this transfers for more than just even maternity care. Emergency care. This is a picture from inside a crevasse. And elders. Let's see. And I'm all out of time. But it does have some implications. Nursing confidence. The community has confidence in their medical care if they can have babies in those communities. We have a healthier healthcare system. We're in the black. We're one of the only rural hospitals in Alaska that is. And there's an economic impact. It's about $1.6 million per family physician that stays in the community. And so, and that's what it's all about. Family physicians want to deliver babies. It's about 1/4 come out of residency expecting that they're going to do OB. The biggest impediment is that they can't find jobs. And so there is a strong desire to do it. They have the training, but just finding it. And we apportion according to the rest of the community. So about 17% of us are living in rural communities. And that's the next generation. And we need to bring them into where they'll be able to provide obstetrical care in rural communities. And there was a mention, too, about rural residencies, super important, because graduates will stay within about 100 miles of where they trained. And so we really do need to have more rural residencies. It's interesting, medical students are actively talked out of family medicine, and especially rural family medicine. And that is a culture that we need to change. And I know that it is a slog, and it's an uphill one at that, but I know we can do this. I've been doing this for 25 years. There is a resurgence in interest among medical students in doing this. We just have to get them trained and into those communities. Thank you.
Good morning. I'm Jean Howe. I'd like to begin by respectfully acknowledging and giving thanks to the Piscataway and Pamunkey tribes on whose ancestral lands we are meeting, and by acknowledging all indigenous peoples as the traditional owners of the lands and waters of the United States of America. I join you as another visitor from rural America, in my case from the Four Corners region of the Desert Southwest. I'm an OBGYN and I work for the Indian Health Service on the Navajo Nation in Shiprock, New Mexico. I work at a 60-bed hospital that is 4 hours by road, 1 or 2 hours by air from the nearest MFM specialist and tertiary care facility. My colleagues and I serve a high-risk population with many patients who are coping with diabetes, hypertension, obesity, and all of the many ills associated with rural poverty and racism. My site routinely also receives patients from more remote clinics and hospitals. The National Vital Statistics Report for 2017 attributes nearly 30,000 births to Native women in the U.S., with Native babies being delivered in all 50 states and the District of Columbia. There are federal and tribal labor and delivery facilities in 7 states. Okay, this advancer and I are not getting along. Let's try again. In 7 states, accounting for just under 25% of these births. Federal facilities account for 8% of Native deliveries. Many more IHS tribal and urban sites offer prenatal care services with referral for delivery. Is the battery getting tired? Am I not doing this right? There's the numbers. And you can see where many of the federal, tribal, and urban clinics are situated across the country. As we've discussed, one of the biggest challenges rural women face is accessing prenatal care close to home. A low-risk pregnant woman may have 10 or more prenatal visits. If services aren't available nearby, this could mean missing over 2 weeks of work for travel to care before she even thinks about maternity leave. And for a high-risk woman, such as the ones we take care of frequently, they may need 20 or 30 visits, and the burden of accessing care as recommended is often insurmountable. Indian Health sites have a range of programs to support pregnant women in their communities. At my site, for example, our patients with diabetes and pregnancy receive prenatal care, diabetes education, nutrition counseling, fetal surveillance, and case management services and integrated visits. We offer vouchers for fruit and vegetables for those experiencing food insecurity. We have mental health services available on site and are working towards co-locating these services within our clinic. We are able to deliver the majority of our patients. Those at highest risk are transferred to tertiary care facilities for birth. And I got ahead of myself. I am so sorry. Robust public health nursing programs are another strength of the Indian Health model. Public health nurses provide outreach services, home visitation, depression screening, and maternal and newborn assessment. PHNs also provide essential support to breastfeeding mothers and our baby-friendly hospital initiative. We also have specialized home visitation services. For example, an evidence-based program developed by the Johns Hopkins Center for American Indian Health called Family Spirit is in widespread use. Family Spirit provides a structured curriculum for young parents from pregnancy through age 3. More pretty pictures. In addition to providing quality prenatal care close to home, we work hard to assure that our facilities offer safe birth services. We have worked with the ACOG Committee on American Indian and Alaska Native Women's Health for nearly 5 decades. ACOG provides us with site visits, program reviews, and education activities tailored to our needs. We are actively engaged in AIM bundle implementation, advanced life support and obstetrics training are also training, and we participate in our state perinatal quality collaboratives and MMRCs where available. Our success in maintaining low cesarean delivery rates and in offering vaginal birth after cesarean services at appropriately resourced facilities have received national recognition. Over the last 12 years, the birth numbers at Indian Health facilities have declined nearly 30%. Some individual sites have experienced even more precipitous drops, especially in rural and remote areas. Factors contributing to this change include the demographic transition to smaller desired family size and widespread rural to urban migration. Infertility rates may also be a factor. To assure safety at low volume sites, we work with ACOG and others to develop specific guidance for rural facilities. When birth numbers have dwindled to very low levels, such as 1 or 2 deliveries a month, some sites have transitioned to long-term diversion status. And to go back, this is a facility that you can see the now closed birth facility, the ER bay where people are now triaged and prepared for transport, and the helicopter waiting outside. This brings me to the most urgent challenge facing pregnant women across rural America: how to access pregnancy-informed care in an emergency. Our sites on long-term diversion status have maintained prenatal care on site with local midwives and physicians who collaborate with off-site OB and MFM consultants. These same clinicians have also closely worked with the emergency departments and helped prepare the emergency departments with the necessary medications and equipment, done drills and training with the staff, and made sure that the ERs are ready to deal with these pregnant women. Uniquely to our system, I think these same prenatal providers provide a backup level of call, even though they're not offering deliveries on site in any planned way. They occasionally do need to do a delivery on site, but they also come in and assist with transfer and triage needs. They often struggle to arrange the transfer, sometimes having to call many tertiary care facilities before the patient is accepted, and several transport companies to arrange the movement from point A to point B. Sometimes the ambulance or air transport system will only agree to transport the patient if the physician or midwife actually accompanies the patient on the travel. As is true of many rural EDs, physician and nursing staffing is often provided by short-term contractors, and that calls out to standardization nationally of what ER should have to be ready. If we have 20 different locums and 15 different nurses rotating through a hospital, they're not necessarily a cohesive team. They don't work together every day. It's kind of like, nice to meet you, let's take care of this emergency. So we really need to pay attention to national standards of what ER should do to be ready. We have them for ACLS, we have them for ATLS, we need them for pregnant women as well. For us, our OB resource clinicians are helping with that, and we're working on programs to support that. I think another piece of that going forward will be the telemedicine resources to support rural emergency care. But pushing the button on the wall to talk to the ER doctor in the big city isn't what's going to help our clinicians. They need to talk to the maternity care person at the tertiary care facility who will ultimately receive that patient and be able to give them good guidance. And if that person was able to say, oh, get out the postpartum hemorrhage kit and open the Bakri balloon and think about this medication or that intervention, that would be exceptionally helpful. We also need better transport resources and enhanced regionalization so that our receiving facilities are ready for our patients. In summary, I am proud to work for the Indian... I'm so sorry. I am proud of the work that IHS and tribal hospitals have done to provide community-based high-quality prenatal care, to keep rural hospitals open for delivery where possible, and to address ED safety. To provide needed care to Native women across America and all rural women, it is imperative that we address these needs directly. Prenatal care must be provided close to home. Safe delivery services should be strategically located across rural America, and emergency department readiness is essential. And this clicker still isn't working for me. Thank you. The green apparently.
Well, thanks very much. Really appreciate the opportunity to be here. In the next 45 minutes or so, no, not really. We'll try to get through pretty quick. I really appreciate the ability to be here. There were a few things we were asked to talk about. Some of this you've already heard, the maternal health challenges. We do know that the closure of services and or facilities is a complex issue. It's multifactorial. There's no one direct problem and contributing factor, and likewise, there's no one direct solution, but we all got to work together to do that. The other thing, Wanda talked to us, and we've already heard about some of the data. I think some of the challenges for us is some of the mortality contributors have changed, such as cardiovascular disease. It used to be hemorrhage, VTE, and sepsis were the big three, and now it's sort of shifted, and it's also shifted in some of the time. In fact, in the recent MMWR, nearly 12% of women died beyond that first 6 weeks of the postpartum period, and it's also different depending on the population. So a whole different mindset. If we're really going to attack this mortality issue, we've got to change the mindset on what we're doing. So certainly from an organizational perspective, there's a lot going on to try to address the rural health issue. We had a great meeting I guess it's been a couple of months ago now, with AAFP and NRHA to address a number of issues related to rural health closures. Lee talked about the AIM bundles, and Jean also addressed them. Certainly one significant contributor to try to improve safety. We're going to talk a little bit about the MMRCs and the perinatal quality collaboratives, and then levels of care. So we were asked to just briefly address PQCs and MMRCs. So the PQCs are these networks of multidisciplinary teams whose goal is really to take established guidance or interventions that are improve safety and get them implemented on a broader and broader scale, certainly at the community and then in the state level to scale up those interventions. All right, I think I'm getting the first. There we go. The MMRCs are a little bit different. They're also state or regional level committees, but their job and their role is to really review maternal mortality. But the important thing is you don't just put your blinders on and only look at the clinical situation. You look at everything that factored into that. What are the system contributions? What are the population contributions? What are the community contributions? Did the women recognize she had a problem, but she didn't have a car and she couldn't get the transportation to get to the hospital? It's just looking at the much broader picture to try to identify those factors that contributed to the outcome, and if it was preventable, and if it was preventable, what can we do on that broad scale to try to prevent that? So with that, it's prioritizing interventions, the resources, the efforts to try to address that. So one of their main goals, again, is to determine preventability, look at the system-based factors such as the social and non-medical contributors, try to identify those, and really try to develop interventions to help target that. So for one of the examples in 2018, Illinois recognized that mortality was highest for rural counties and in the city of Chicago. And while there might be some common characteristics or risk factors, very likely they're very different. And I think one of the main messages, one size does not fit all. You can't have one intervention that's going to fix this entire problem. It really needs to be targeted at what the major contributing factors are. And their cross-collaboration, again, if you think about the PQCs are sort of the implementers of these programs or interventions to improve outcomes, the MMRCs are identifying what those problems are and what the potential interventions are. So it's the findings from the MMRCs that can be provided to the PQCs to try to implement these interventions on a larger scale. So one example is in Florida. The MMRC identified hemorrhage related to placenta accreta as a significant contributor to mortality. So the PQC then translated that into a QI project to improve outcomes for accreta in Florida. In Michigan, another one related to substance use, how the findings from the MMRC could then be translated into a program by the PQC to improve outcomes. So how do these translate to rural health? They both do. So the PQCs are a little bit more challenging if the rural hospitals are not part of the healthcare system, because they may not be engaged with the PQC or may not have the infrastructure to implement a QI project or something to improve the program. Those who are in the systems may have better ability to participate because hopefully the system hospitals are reaching out to them. That doesn't mean that the hospitals that are not in systems need to join one, but it's really developing the networks and the ECHO programs that were briefly addressed before, and the use of telemedicine to try to improve the outreach. The New Mexico and Utah programs are great examples. The hospitals don't necessarily have to be in the same financial system, but there's outreach capabilities in order to provide and extend this level of education, quality improvement, and care to rural facilities. So it really is a good way to cross-contaminate, so to speak, and get the message and get the resources out there. Same thing for the MMRCs. It's really critical that the MMRCs include rural health component, and the good thing is most of them actually do. But I think one of the things to focus on, even though maternal mortality is higher than it needs to be, fortunately it's still a relatively low rate. And because the volume is typically less in rural facilities, the rate's going to be lower. So if you just look at the rate, it's not necessarily going to tell you what's going on. It's not necessarily going to be a reflection of what the real issues are. So it's really important that the rural issues are addressed at the MMRC. And again, tying back to the example in Illinois, the risk factors and the interventions may be very different in that rural setting compared to an urban center. A little bit of discussion today about postpartum care. Our prior President Haywood Brown, that was one of his presidential initiatives to redefine, to change the paradigm, that it really is all about pregnancy is a stress test. That's one of his quotes, and pregnancy is a window to future health. To identify those problems in pregnancy that might reflect downstream, longer-term health care issues for women, such as preeclampsia with long-term hypertension, gestational diabetes with higher risk of diabetes downstream. So really shifting the whole postpartum mindset that we need to do earlier interventions to identify those more urgent issues, but then we need to translate into ongoing care and making sure that those women are plugged in so they get the necessary downstream care. Another initiative, and we've talked about, a few people have talked about this, telemedicine and telehealth. Clearly an important tool, an important aspect. ECHO is another demonstration of that. The technology exists, but we also know that there's problems that we need to overcome in order to have this more fully implemented. But it can be overcome, and it is an important aspect to extend care. We can't force people, at least yet, to live somewhere and practice somewhere. So until then, we need to bring the medicine to the patients and not drag the patients hundreds of miles to where the medicine is. So shifting gears a little bit to levels of maternal care, this was the original document published several years ago. Actually, this is in the review process currently. And the whole idea behind levels of maternal care is to provide some consistent framework to identify capabilities and resources, and maybe even more importantly, to identify the resources and capabilities you don't have, so you recognize which patients need to go to a facility with higher resources. Diana used, I think, the comment, right place, right time. That's what it's all about. I recognize that the patient has additional needs, get them to the place that has the resources that can take care of her. The original was endorsed by a number of organizations. We hope the same will happen with the revision. It's relatively straightforward, but basically level 1 is uncomplicated and low risk, and the risk escalates as in correlation with the increased resources at the higher level facilities. So for time, we're not going to spend too much time on this. Once the document was published, we thought, oh, this is great. We've got a document. It's going to sit on someone's shelf. Great. So we decided we need to translate this into an implementable program. So we partnered with a number of organizations to create basically a verification program. The CDC already has Locate, and many of you may be familiar with that, which, although oversimplified, but is really a way for facilities to self-assess and self-report their levels based on their interpretation. The idea then was to create a verification program to go to visit hospitals to verify their compliance with the criteria according to the levels. So I'm going to basically skip this slide because we developed a verification program that included pre-visit, on-site, and post-visit activities. And we piloted that in 14 states, 14 hospitals over several states. Importantly, we wanted to include Wyoming to address some of the same challenges you've heard about rural health and some of the geographical and weather-related limitations to really understand how it worked. And with that, we have materials ready to help people implement levels of care who are interested in doing that. There's certainly increasing interest in doing that. Chris Box from Indiana is here. We've talked with Chris about the work that's being done in Indiana related to levels of care. It's a growing area. While we were doing that, we also partnered with Texas. Texas actually legislated a levels of care system, and we're one of the agencies that are actually conducting the verification site visits in Texas, and we've done about 60 or we have 50 or so either done or scheduled, and importantly includes rural facilities to really look at it. And I think the important thing is that this is not it's not Big Brother coming in and trying to put the squeeze on. It's a very collaborative process, educational, supportive, counseling and consultation. So it's really been very well accepted. I'm pretty much out of time, so I'm just going to skip on. In the process of revision, one of the things we learned, we convened an implementation meeting because there were a lot of questions, so we want to create an implementation guide, a series of FAQs to help provide some clarification on the document. We also had a great meeting with NRHA and AAFP, and really want to thank John and Julie and colleagues from AAFP to recognize some of the issues, particularly the importance of family medicine physicians at, for example, level 2 hospitals and the role played, particularly in the rural setting. And our goal is to provide a commentary to address some of those issues, the importance of the team network, payment reform, the regionalization is important. Got one more. I'm going to get the hook here pretty soon. And then data is really important. We need to collect the data on the outcomes to show that interventions like this really do have an impact. How does levels of care in rural facilities relate? And I'll be transparent. We've gotten some criticisms that levels of care is contributing to the closure of rural facilities. I would argue it's the exact opposite. That our goal is through regionalization is to support level 1s and 2s. We know that level 1s and 2s, which include the rural facilities for the most part, do the majority of births in the U.S. We can't afford to close them. But the concept of regionalization, putting the onus of responsibilities on the 3s and 4s to provide the outreach, education, support, quality interventions, really helps to keep women in their communities and really helps to keep the level 1s and 2s supported. So the whole concept of regionalization is designed to help rural facilities in 1s and 2s, not to threaten them. And with that, thank you. I just want to say one more thing. We really appreciate, with all due respect to the neonates, I was one once, in fact, we all were at one time, but we really appreciate that the moms are getting the attention. So, thank you.
Okay. Kara, how much time do we have for questions? Realistically? 50? Okay, great. Good, because we got 30 minutes worth of questions, so that should be no problem at all. Anyway, so folks can start making their way up to the microphone, and if you would, just like in the first session, if you could tell us who you are and then specifically get to the question, that would be great. And while you're doing that, we did have a couple questions come in online, and I think, Dr. Zahn, this is a point you sort of made, and a question came in similar. What would the panel's suggestions be for the mainstreaming of addressing sort of the socioeconomic inequities that go beyond the four walls of the clinic?
Well, I can start with that. I mean, certainly levels of care doesn't specifically address that, but I think inherent in the whole concept is that with the levels of care and the support, particularly for the level 1s and 2s, it helps to maintain access through the outreach of providing quality initiatives, certainly addressing social determinants. Some of the inequities that occur should be part of that quality outreach. And I think importantly for level 1s and 2s, and probably for mostly for level 1s, it's really difficult for some of these hospitals to develop these quality initiatives, or maybe not so much develop, but implement them and carry them out. And that's the importance, I think, of the level 3s and 4s helping to provide that, because it's really a regional problem, and it should be a regional activity. It shouldn't just be one facility's in charge of it, and then there's no support for it.
Any thoughts? Go ahead, John.
So there's, I guess, wearing both hats. First, as a rural physician hat, the nice thing about being a rural physician is you actually get to see firsthand what the social determinants of health are and the impacts they have on your community. And as a family physician, I get to see that in my office. So even though I'm seeing people in the office, it's really it extends much beyond that into the community at large. I mean, it's we know everybody. All of our patients are our friends or our neighbors, and so it's something that is very clear about what's happening. From an American Academy of Family Physicians hat, this is something that we are really focused on right at the moment, is dealing with the social determinants of health. We actually have a new Center for Health Equity that specifically look at that. We have some initiatives around coming up with a new kind of electronic health record that actually has social determinants of health as a component of that. So we see that the social determinants of health are probably a larger factor for the health of our patients really than any of the medications that we can prescribe. And so we really are focused on this at this point to see if we can't really bend the curve on this issue.
Diana?
I would add to both of these comments just that in order to address the social determinants of health, we need to hardwire the care that's proven to lead to changes in outcomes. So that is not our traditional payment system. Community health workers and peer counselors are more effective at addressing major issues related to drivers of obesity, diabetes, cancer, heart disease. We need to embed them within our system. When I care for 23-year-old women who are hypertensive because 4 people have been shot in the 4 blocks that live around them, we're not going to change anything in the medical office. It's changed in the yoga room and in the healing studio through behavioral health and through support. And if those things aren't built within our payment structure, then we're institutionalizing the lack of access to the appropriate level of care.
Great, thank you. There was a question earlier also about could more be done in terms of rural GME and medical education. And I think it's a really relevant question because most physician residency programs, obviously, folks know, are in urban areas. We are seeing a change in that. I think the Teaching Health Center program that HRSA administers is a good start in thinking about integrating some of what you've heard today. And by the end of this calendar year, we will fund at least 25 new rural residency program planning grants to get new residency programs going. And so I appreciate the sentiment today because I do think we need to think about both those programs and how we can think about making sure they account for the issues that were raised today. So we'll take that back. Katie?
I'm Katie Quasimodo, and folks know me already. So my question is, how can we, building off the prior responses, how can we change our perspective, as Diana asked us to do, to think, instead of thinking about the lack of things in rural communities, think about the resilience and capacity and positive things. Many of the social determinants of health in rural communities are actually positive and protective in many ways, whether that's knowing the people who take care of you, knowing your neighbors. How do you see the positive aspects of rural communities informing how we think about whether it's levels of care or broader maternal health issues? And I specifically do want to ask about levels of care. How are we thinking about those communities that aren't planning to do births, but where births occur anyway? How does that appear on levels of care? Where is level 0? How does that come into play in rural communities where births occur, but there aren't hospitals or facilities that are prepared to handle that? Sorry, that was 2 questions.
Start with Lee.
Yeah, I think this is relevant to rural communities. I think it's relevant overall. But one of the things from the summit that we learned and heard loud and clear, not only from some of the women in the audience who were experts in the United States, but from around the world, was the importance of not relying on the healthcare system to be doing it all and fixing it all. I think we are at a unique stage with technology and information and access, and we don't rely enough on providing more and better information to women so that they can have more voice in saying what they need, what is not working for them, and how they should be accessing care and getting the treatment that they want. And I think when it comes to rural women, I think, you know, given the scarcity of resources and the fact that, like, not everyone, people don't have just one job in rural areas, they do multiple things, they are adaptable. And so the idea that with, like, our Well Women activities and our WIPSI products, with Bright Futures, with some of these other initiatives that we're putting out there, the idea is to encourage women to ask the questions of what do I need, how do I feel, and how do I express that in a way so that I have a voice and I can tell the doctor or the nurse or the midwife or my partner when something is not right. And whether or not I need something more or different. So I would like to encourage this idea, and it's one of the things that's infused through our approach with a more public health perspective as opposed to just paying for reimbursement, that we need to look at systems that engage the individual and allow them to work within their community.
John?
So I think that I had a slide where the outcomes were actually a little worse for people who went to metropolitan areas to deliver, and I think it's just for precisely that reason, is that we're taking women out of their support structures, away from their families, away from the other members of the community that really support them. And then putting them into a foreign environment. And it's hard because a lot of times people from the city can't understand why somebody from a rural community wouldn't want to stay in the city. I mean, that would be great, right? And we act, and I say this coming from growing up in a city, but we try to avoid cities like the plague. And so I think that's one of the reasons that the outcomes are worse, because it does cause a tremendous amount of stress to be outside of those structures. The second part to your question is what do you do with level 0 hospitals? Because I think that really is a thing. And unfortunately, what has happened is that a lot of hospitals felt like they could not do an adequate job of delivering obstetrical care. A lot of that has to do with an economic argument. We have a tendency to think of in hospitals about service lines, and service lines, obstetrical service lines, have the tendency to lose money. And so if you look at it from a silo perspective, then offering obstetrical care doesn't make as much sense. We have to look at it from a global perspective within that community. And the thing is that taking away obstetrical services, it may mean that you're not losing that particular money, but it also means you're not going to be able to handle the bad outcomes from a pregnancy case that you don't have the capability for, because people are still going to deliver in those communities. But what we've seen nationally is that hospitals that give up on their obstetrical care actually lose money overall. And it's sort of the beginning of a death spiral, because by the fact that I deliver babies in my community, that means I have young families, and I have young families, so they stay in schools. Businesses are more likely to come into that community. I mean, it's an economic driver at a lot of different levels. And so when we lose those obstetrical services because kind of a short-sighted view of a service line, it's detrimental and devastating to those communities.
We'll make one comment on that. I'll come back, Dr. Zahn. But I think that rural hospitals face a very tough decision. The boards face very tough decisions when they close an OB unit, and it's a gut-wrenching thing for their community. But there is a need to think about it more broadly than just what that year's bottom line looks like. And so there may be something we want to think about training of boards and better understanding of the larger picture. Dr. Zahn?
Yeah, thanks, Katie. Specifically, so we can't define levels of care if they don't have obstetric service. But it does tie in, because I think with the technology such as telemedicine, that does allow the capability for an OBGYN, family medicine, to talk with community health workers, nurses, that sort of thing, to extend the service in the community. And outreach is another thing. We already see a lot of 3s and 4s provide outreach. I know in Texas, some of the major centers in Houston provide outreach throughout the whole southeast area of Texas, which has no OBGYNs. So people are getting in the car, driving a couple hundred miles, seeing a couple of days worth of clinic before coming back. So it does, even without the service available or the providers, there's still ways to bring the level related care to the patients instead of the other way around.
Dr. Howe?
Yes, so for the women that we serve in rural areas, having prenatal care close to home is essential. But I'm particularly concerned about the idea that we can't define what level 0 looks like. I feel like we want to keep birth centers open wherever possible, but when a birth center needs to be on diversion because numbers are so low that we can't provide safe, routine, planned delivery there, we can't just throw up our hands and abandon that site. We need to think about what's needed in that ER, and we could define standards for ERs. What equipment should they stock? What medications? Who's going to be called to help in an emergency? And how are we tied into the larger network in our state or region?
Great point. Dr. Barfield, do you have a question?
Yes, so the question I had was one about training. And you talked a bit about issues with regard to training, but I think, medical education has shifted in that there's reduced hours, yet it appears in rural settings there may need to be a real different frame in terms of how you cover for care given maybe a limited resource. And I was wondering if you could talk a bit about that, of how you might be framing things differently in rural settings in terms of this teamwork. And then the other issue is, there was a time when we would reimburse or provide funding or loan repayment if physicians would serve in rural or in Indian Health Service, and that has sort of gone away. And what do you all think in terms of that as being one way to get these, especially some of the newer physicians, the opportunity to work within rural settings as part of their education after training?
Panel? Anybody? Go ahead.
I will just say I'm a loan repayment recipient, and when you get people out to the rural areas, often they do stay. The investment of repaying my med school debt over 3 years resulted in 22 years of my service. So I appreciate that, and I wish that the loan repayment availability had kept up with the high price of medical education.
John?
Yeah, so the average medical student debt right now is about $250,000 to $300,000, and so the reality is that students coming out will actually, as soon as they start residency, start having to pay on that particular loan. So loan repayment is incredibly important. And that is something that's very important for communities to be able to offer. My community actually is putting up $60,000 of loan repayment just from the community itself. And you think about the return on investment at $60,000 a year, but every family physician generates about $1.6 million of activity. That's not just hospital charges. I've heard as high as $2.4 million. So the return on investment is just extraordinary. And so the second part, I think, is how do you do training? So it's interesting. Every physician in my community did a rotation there as a resident. And so having residency rotations in these rural communities is absolutely essential so they can see what it's like and be a part of the team. We have OB fellowships and rural medicine fellowships that started in family medicine, although there are some residencies that have numbers that are really quite good, such that they can really go into a rural community right after a 3-year residency. Having said that, it takes me about 3 years to train a new graduate from residency to the point where I feel comfortable leaving them alone. And so really for rural medicine, a lot of times it's almost like a 6-year process after graduating from medical school. I get frustrated when I hear that the solution for rural healthcare is to have less trained individuals go there, and the reality is that you need higher trained individuals, and it's scary because one of the way we've always done this is that by having an older physician who served in a mentorship process. That's how we've always done it. That's how I did it when I moved to Valdez, is I had 2 partners who had been there for a lot longer than I, and they taught me things as well. A lot of those mentors are potential mentors are actually retiring, and so this is a crux point right now that we really need to focus on rural medicine to get young physicians out into those communities, and I think loan repayment is a big part of that.
Dr. Zahn, did you have something?
Yeah, I think, certainly Gene is a testament to that. I think we also have data from the military. I mean, the military is basically a loan repayment program. I was former Air Force, which is better than the Army, by the way. And, a lot of people, when the residents would graduate, clearly there's desirable assignments and not so much. And I can distinctly remember residents being dragged kicking and screaming to those places they didn't want to go. And when they got done with their payment, they wound up staying in the community. So there's evidence that it clearly works. And if there was a system in place to loan repayment, additional stipends, however it's done, to get people you just have to get the people there. And it's likely that a good number of them will stay.
Dr. Jallis?
I just want to make 3 comments. There's a myth going on that we have understood the amount of volume you need to be a competent provider. And I sat in a very busy urban setting a week ago where the chief of OB was talking about how she had 1,000 births before she left residency. And I thought to myself, wow, I'm entering the last half of my career at 1,000 births, and I feel like I've had the best career, and I'm so satisfied, and I have been providing high quality care. But her perception was that she left residency with that, and that if you don't have 1,000 when you leave, that you're not competent. And I want us to really look, when we're looking at our interprofessional training programs, to stop and question our assumptions about that. What we need to do train the community members in their community to serve their community. There are Navajo nurses who will make far better midwives than me sitting there right now, but they don't have funding. And as a previous service director, I can say, I can't hire National Health Service Corps scholars or loan repairs if I don't have the liquid assets. So we need more support for the sites to pay salary in addition to the compensation for loan repayment.
We have time for one more question in the back.
Hi, my name is Courtney Gustin. I'm a nurse midwife. I work in the Office of the Surgeon General here in DC, but I previously worked at the Alaska Native Medical Center in Anchorage. I'm wondering if you can address how barriers to practice, whether for nurse midwives, nurse practitioners, family practice physicians, affects the ability to provide collaborative care models and also just to provide care providers at all in the rural areas.
If you looked at some of those maps we were presented today, we should be appalled at the red southeastern states where people are dying and where you can't practice to the full extent of your scope. I mean, it's criminal, and we as a nation owe the community more.
Any other thoughts on that for the panel?
Yeah, just briefly. The innovations program that I had mentioned to you earlier, the new resources that we were provided in 2019, this is one of the issues that we are asking applicants to consider proposing, is strategies for helping to allow healthcare professionals to work to the maximum level of their degree and their training, and how they might look at the restrictions that have been built up, some over time, some are legislated or mandated, and some are just general practice, but ways that they might be able to identify those limitations and barriers and try to improve upon resources that might already be there, or shuffling resources around within the state or some other way to make it attractive for people, nurse midwives to practice more, or for people to move around the state or whatever to provide that sort of care. So we are very actively trying to pursue that effort.
Dr. Howe, I think you had a comment.
I just wanted to acknowledge the many midwives that serve Native people across the country. In very rural communities, a midwife who knows her patients well, who they trust and come to see her regularly, is probably going to be able to provide a higher quality of prenatal care and seek appropriate consultation for the high-risk patients when needed than asking people who don't have gas money to get in cars that they might not have either and drive a long way to get a really quick visit in a busy urban clinic. We are seeing more Native midwives come through the system, and it's very gratifying to see them, in particular, have the opportunity to serve their own communities.
We'll close out with John.
Yeah, I think that having those collaborative teams is really important. And although we don't have midwives in our particular community, it's mainly just because of just a sheer workforce, because of the small population size. But I've seen that model work before, where it's worked very well with collaborative obstetricians, family physicians, and nurse midwives. And I think that really is an ideal model to have, because we all bring different things to the table, and or bring to the exam room. And so I think that is, and I've learned just a huge amount from both obstetricians and from nurse midwives in the course of my training. I was just recently talking at the ACOG conference where I said that in terms of rural health care, or the obstetricians can't fix it without family medicine. But family medicine can't fix it without obstetricians. It's something that we need to be working as a partnership, and I think that all three, we need to be working together very closely on this to solve this. This is going to be a multidisciplinary response if we're going to actually get a hold of this whole problem. And we need to, because it is absolutely unconscionable what is happening in this country.
Great. Thank you, John. We're going to ask Kara to come up. Join me in thanking the panel, if you would.